I will talk a little about the use of SEOs in relation to percutaneous interventional procedures. This is at my heart. This is what I do a lot. I use a lot of intervention. I use a lot of contrast. To combine the two is a very good thing. So again, you can speculate what this is. I don't know if you know what it is, but if you know it already, keep it to yourself. But I will tell you in the end what it is. It's amazing imaging, but it's a fantastic thing actually. Well, this is the hospital I work at, Herlev Hospital in Denmark. You can see it from high in the sky because it's actually the tallest building in Denmark. This is how it looks at night, very beautiful. This is our auditorium. This is my old professor, Professor Hans Henrik Holm. He died last year, high age. He is the father of interventional ultrasound, and he made interventional ultrasound a very good tool, and he made it famous around the world. He taught me this. Whenever you see, and I started back in 1986, I think I started. When you see something in the liver or anywhere else, the first thing you do is you ask for the needle. And ultrasound diagnosis is scanning plus a biopsy. So we didn't ask the referral doctor, we took the biopsy and sent the patient home, said if you get pain, come back. But the times have changed. Bob Dylan's tune, you know that, times are changing. So contrast agents changed our way of thinking also on interventional ultrasound. So I still use a needle. I don't put the needle in the liver, I put the needle in the cubital vein. Actually, I don't put the needle. When I'm scanning, my nurse, she can see on my hands, he wants contrast. So while I'm scanning, she takes the arm from the patient and she put the needle. So, and she injects Sonovy and then we take it from there. Why should we use SEOs for guidance of interventions? I have a number of indications. One of them is not this one. If you have a typical lesion and if you have a typical SEOs, we don't need a biopsy and we don't need SEOs guided biopsy. This is a metastasis. But that is not always the case. Sometimes we have invisible or just poorly visualized liver metastasis. For instance here, this is you see it on the SEOs, you see no lesion on the fundamental. Again here, this patient had a breast cancer and there was a PET positive metastasis in the liver. Take a biopsy, they said, I don't see any, where is the metastasis? Inject contrast agent and bingo, there is a lesion. Now, you cannot take a biopsy from an invisible lesion, but you can easily take a biopsy from something that is very visual on a SEO study. And it's not different techniques, it's just a matter of changing your game a little bit. So if you can see it, you can easily take a biopsy. Another case here, and this is very often, if you get oncology patient and you do the scan, you should always use SEOs because you detect up to between 15 and 40% more metastases. Now, maybe it doesn't matter if you have 5 or 6 metastases, but it really matters if there's 0 or if there's 1, because he should have chemotherapy or surgery. So we use SEOs ultrasound and we found this one. We could not see it here. What do? We take a SEOs guided biopsy. And you can only do this with SEOs because you cannot biopsy something that is not visualized. Here comes the needle, and it goes through. And this was a colorectal cancer. Here's another patient, markedly elevated CEA, and there was ascites. They want a biopsy. There was no lesion. Contrast agent, you can see most of the liver is totally infiltrated with cancer. You couldn't see it. So there you need ultrasound to take a biopsy. Sometimes, even you use contrast agent, you cannot take the biopsy. This one was sitting so high under the dome of the liver and under the diaphragm, you could not see it. What do? We use fusion. If you use fusion, you know the lesion is up there and you can feel confident to take the biopsy even if you cannot see it. So what is fusion? Just a few words. Fusion is like the weather forecast. Here's the geographical map. Here you have the weather forecast. You put the two on top of each other. That is a fused image. CT and ultrasound can do the same. So you have the real-time ultrasound and you have the historical CT. So now it merges ultrasound with CT. So now ultrasound is the master and CT is the slave. That is a situation we like a lot in ultrasound at least. What you can do, you can fuse any kind of cross-sectional imaging. You can fuse with PET-CT, you can fuse with MRI. And you load the images from the PACS system. So sometimes you don't want, this was a case with a abscess after cholecystectomy. You couldn't see the abscess, you knew it was there, and you could use this as guidance to put the needle in the right place. Okay, you can combine the two, CUS and fusion. I will show a case later. Another good indication for CUS-guided intervention is biopsy of viable areas. You know, when you have big tumors like this melanoma metastasis, very often it is avascular in the center because it is necrotic. If you take your biopsy from necrotic area, you don't get the diagnosis. The pathologist will say necrosis. So here's a case. We found this lesion. We did a CUS and we found out there was necrosis here. Don't take it from there. Take the biopsy from there. And this was actually an HCC in a non-cirrhotic liver. This has been published first time in 2006 by Wu in China. There are not very much in the literature about it, but everybody who uses biopsy and contrast knows about it. So it's a good thing. Another good thing is you can substitute many X-ray studies with CUS ultrasound. Why would you do that? Well, evidently, of course, to spare the patient for the X-ray studies, but also to do the case while you have the patient on the table. I will show you some examples. This was an abscess in the lower left side, and this was a diverticulitis. We put in a catheter. After that, you inject contrast agent to see that there are no other cavities, undrained cavities. So this is what you could call a CUS fistulography. Another case, this was a case with a patient that had a Claskin tumor. I put in a guide wire inside the bile ducts. You have a catheter here. They wanted to know if this is totally occlusion. And afterwards, injecting contrast agent, you would see the contrast agent is filling up the entire biliary tree, but there is no passage through the bile duct to the bowel. So this is a total obstruction of this Claskin tumor. Another similar case, but not the same. This patient came with a mass, a very strange looking mass, but she also had septicemia, so we suspected it could be an abscess. We drained, we put in a needle, and it was really pus coming out. So now I inject again contrast agent, a fistulography, filling up this cavity, but this time I could follow the contrast from the abscess through the choledochal duct, and I could even follow it into the duodenum. So in this case, we could say this patient has cholangitis, there is a fistula, and there is a connection to the bowel system. So this was a very good case of, and you could not do this better with CT fistulography. Another case, very illustrative, multiple simultaneous CUS indication in the same patient. This was a very big lady. She came and somebody found this 15 centimeter mass in her abdomen. This was not in my department. They did a biopsy, and you can see it's very heterogeneous. There's maybe in the center, maybe there's necrosis. They did a contrast study, and they said, well, there is no, they didn't find any kind of they did not do a contrast. They just took a biopsy, biopsy came out all necrotic. They took this biopsy, it came out necrosis. They took from the center. Now, what should next step be? We could do CT, we could do MRI. Next step is actually I put a new needle in through 2 cavities, but I will show you something before. We did a CT, and the CT showed this huge mass. Also, it shows something's going on in the abdominal wall of this obese patient. So they said could be abscess here, could be abscess there. The patient is back, and this is when I did the contrast study. You can see it may look like it's totally necrotic, but if you look carefully, there is an area here. This area is not necrotic. So this area is the one you would take your biopsy from. And then afterwards, I would do diagnostic puncture, first of the central cavity, then of the communicating cavity. So here is what we did first. I took a CUS-guided biopsy of the enhancing area because I know this is viable. This is living tissue. If I take a biopsy from there, I have a good chance. And actually, it came out. The diagnosis was she had a cholangiocarcinoma, huge cholangiocarcinoma. And much of it was necrotic, as it was in the first biopsy without serous, but they also found viable tissue, and that is what made the diagnosis. So if you can use serous, go for the enhancing area. That is the viable area. Then I put in another needle and put it to the center and injected contrast agent. This is what I saw, a cavity in the center. Then I retracted the needle to the peripheral fluid collection, and again inject contrast agent, and you can see another cavity not connected to the first. So this patient, we put in 2 catheters because it would not treat her to put in just 1 catheter. So important to drain them separately since they're not communicating. So in very few minutes, maybe half an hour, we had 4 things: tumor vascularity, serous guided biopsy, serous fistulography, and drainage of 2 abscesses. I'll show just shortly, you can also use in any stage. If you're using ablation of tumors in the liver, serous can be used in every stage. And now here comes where I can combine serous with fusion. This patient had a total of 6 metastases. At this slide here, I am actually ablating 3 tumors at the same time because we used fusion to put in 3 needles, and so ablation is going on at 3 different spots at the same time. After the follow-up, you do follow-up immediately at the same setting while the patient is still anesthetized, and also at any follow-up. And if, like this case, you have an ablation, but you may be suspicious that there could be some recurrence, you use serous guidance to take the biopsy from the suspicious area. In this case, it was recurrence. Now, we have very good results with this. We have technical success of 100% using in 125 metastases, serous for guidance of microwave ablation. And if you look at the results, what is the result for the patient? Actually, if you have only 1 metastasis and you use ablation, you have just as good result as if you have surgery. Now that is very important, and I could speak about that for a long time. The question I see is not who should be offered tissue ablation. In my opinion, it is rather who should not. Why should we go for surgery if you could do tissue ablation? Okay. And the newest thing in ablation is this one. It's called the nanoknife. It is not heat, it works with electricity. Oh, sorry for the sound. It's on mute. Anyway, this works by electricity, so it's not heating, and what it does, it preserves all the tubular structures. So on contrast study afterwards, you will see that the vascular structures running through the ablated area are not dead, they're still there. So, and this is very, very good for pancreatic cancer. My final case and my final point is, if you do intervention with ultrasound, and you are looking for ablation, or you're looking for complication as bleeding, you should use serous. Because here comes my first slide. Now this is a case after biopsy, the patient had pain. I don't know if you would say, but this is actually fresh bleeding. So this patient has fresh bleeding after biopsy. It's very difficult to see because fresh blood clot mimics irregular liver parenchyma. Here is the case from the start. We were doing ablation, and after the ablation was over, I inject contrast agent again. So now you see ongoing bleeding. This patient, I took out my ablation needle, and the bleeding with the contrast agent is pouring out just like a water hose. So this is very severe bleeding, and I was afraid. I call the surgeon, call the surgeon. The surgeon come in, he looked, wow, very beautiful pictures, he said. I said, okay, what about the patient? The anesthesiologist told us, take it easy. I can see on the blood test, everything is over. So look here, this is fresh blood. Look how easily you can see difference from the liver. But then, after 5 minutes, when the blood coagulates, this is liver. This is a fresh clot. I would say many people could easily miss that diagnosis and say this is just liver. If you inject contrast agent, you have no doubt. This one here is not taking up any contrast agent. That's why it's black. So you would know this is a fresh clot. You could easily make a false diagnosis on the other one. So contrast agent is very, very good for monitoring bleeding. And that is why it is also used in trauma for triage. Remember that. That could save you a lot. Okay, so in conclusion, SEUS and also fusion there are several numerous indications, and you just use your imagination because there's no end to it. Why are we so good in intervention in Denmark? Because this is from our ancestors, the Vikings. They put interventions to everyone. Thank you for your attention.